Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 526 of our pharmacotherapy series, which majors in renal dialysis. This case refers to patient KMJ discussed in part 525 of this pharmacotherapy series. If KMJ was receiving APD instead of CAPD, would the treatment of her infection be different? Cycler machines automatically cycle dialysate into and out of the peritoneal cavity in APD. Patients having CCPD will generally need 3 to 5 exchanges, each lasting approximately 2 hours, using a cycler while the patient sleeps. During the daytime hours, the patient maintains a reservoir of dialysate in the peritoneal cavity, resulting in a long dwell. The cycler process repeats at night. 6 to 8 exchanges are performed every night for patients having NIPD. The peritoneum is left dry, and patients do not continue dialysis during the day. Nightly dwell times are generally 1 to 2 hours for each exchange, resulting in a higher clearance for small molecules because of the increased dialysate flow rate. For patients having APD, the choice of first-line antibiotics is the same as for CAPD because the likely organisms are similar. Drug dosage regimens, however, can differ because patients having CCPD or NIPD undergo peritoneal dialysis only during the nighttime hours, and those having NIPD do not have residual peritoneal fluid during the day. The rapid exchanges in APD may lead to inadequate time to achieve therapeutic drug concentrations. The dose of cefazolin in APD is 20 mg per kilogram, rounded to the nearest 500 mg, every day, in the long day dwell. KMJ should receive cefazolin 1,500 mg intraperitoneally in the long day dwell. A concern is that patients given a single dose of a cephalosporin during the long day dwell may have intraperitoneal levels at night that are below the MIC of most organisms, allowing biofilm-associated organisms to survive, resulting in relapsing peritonitis. A safer approach would be to add the cephalosporin to each exchange in APD. Because of the lack of clinical trials with other antibiotics in patients having APD, extrapolation from the CAPD literature may be necessary. A review addresses the current knowledge and issues surrounding the pharmacokinetics of antibiotics in patients with peritonitis undergoing APD. Catheter exit site infections are a significant risk factor for developing peritonitis. So my next question to you is, what information should be provided to educate KMJ in daily catheter care? Recommend an appropriate antimicrobial cream for KMJ to administer around the catheter exit site. Prevention of catheter exit site infections, and thus peritonitis, is the primary goal of exit site care. Several preventative measures are important: adequate catheter placement, dedicated postoperative catheter care, and routine daily care of the exit site. Dressing changes of a newly placed catheter are done by a dialysis nurse using sterile technique until the exit site is well healed, which can take up to 2 weeks. Once the exit site is well healed, KMJ can be educated and trained to do routine exit site care, including thorough hand cleansing before touching the exit site by rubbing both hands for at least 15 seconds using antiseptics that contain at least 70% alcohol or antibacterial soap. The exit site is then washed daily with antibacterial soap, although use of an antiseptic, e.g., povidone iodine or chlorhexidine, is a reasonable option as long as concentrations are non-cytotoxic. Hydrogen peroxide should be avoided as a routine antiseptic because it causes drying. After daily cleansing, KMJ can be instructed to apply antimicrobial creams, e.g., mepirocin, gentamicin, around the catheter exit site using a cotton swab. Mepirocin ointment, not the cream, can cause structural damage to polyurethane catheters and should be avoided in patients with these catheters. Catheter exit site infections are most often caused by Staphylococcus aureus and Pseudomonas species. In a randomized, double-blind trial, gentamicin sulfate 0.1% cream was found to be as effective as mepirocin 2% cream in preventing Staphylococcus aureus infections. Gentamicin cream was also highly effective in reducing Pseudomonas aeruginosa and other gram-negative catheter infections, whereas mepirocin cream was not. A longer time to first catheter infection and a reduction in peritonitis, particularly gram-negative organisms, was also seen with gentamicin use. For these reasons, daily gentamicin cream at the exit site is considered to be the prophylaxis of choice in patients having peritoneal dialysis and would be the preferred treatment for KMJ. Finally, the catheter should be immobilized with a small gauze dressing and tape to prevent pulling and trauma to the exit site, which may lead to infection. My next question to you reads: if KMJ were to exhibit an exit site infection, despite appropriate catheter care, could oral therapy be used or is intraperitoneal therapy required? Empiric therapy for exit site infections may be started immediately and should always cover Staphylococcus aureus. Oral antibiotic therapy has been shown to be as effective as intraperitoneal therapy with the exception of methicillin-resistant Staphylococcus aureus infections. Local erythema alone can be treated with topical agents, whereas purulent drainage indicates more significant infection and the need for systemic antibiotics. Gram-positive organisms are treated with first-generation oral cephalosporins, or with oral penicillinus-resistant penicillins. Rifampin may be added at 600 mg per day orally, in single or split dose, for slowly resolving infections. It should not be used as monotherapy, or in areas where tuberculosis is endemic. Rifampin is an inducer of drug-metabolizing enzymes and concurrent medications should be evaluated for potential drug interactions. Oral quinolone antibiotics are recommended as first-line agents in the treatment of Pseudomonas aeruginosa exit site infections. Monotherapy is not recommended because resistance develops rapidly, and Pseudomonas aeruginosa infections are difficult to treat, often requiring prolonged therapy with 2 antibiotics. If the infection is slow to resolve, or if in cases of a recurrence, a second anti-pseudomonal drug can be added, e.g., ceftazidime intraperitoneally. Gram-negative organisms can be treated with ciprofloxacin 500 mg orally twice daily. Scheduling of the quinolone dose is important, so that co-administration with foods or other drug therapies that may chelate the quinolone in the gut is avoided. Potentially chelating agents include calcium products, iron, multivitamins, antacids, zinc, sucralfate, and dairy products. Antibiotic therapy should be continued for a minimum of 2 weeks until the exit site appears entirely normal. My final question to you reads: KMJ is noted to have gained weight since starting peritoneal dialysis. Besides fluid retention, what other possible cause is there for the weight gain? How might this affect her insulin requirements? The correct response is: dextrose is present in dialysate solutions primarily to serve as an osmotic agent for the removal of fluid during each exchange. Higher concentrations are expected to result in greater fluid removal. Approximately 500 to 1,000 kilocalories per day are absorbed as glucose from peritoneal dialysis solutions, which can lead to weight gain in patients. Some patients may require modification of oral caloric intake to avoid excessive weight gain. Insulin requirements generally are increased in patients with diabetes as a result of the additional calories and, when administered intraperitoneally, usually at 2 to 3 times the normal subcutaneous dose because of their reduced bioavailability of 20% to 50% by this route. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 527.